Since morning and since probably yesterday, we have talked about all the drugs, DPP4, SGLT2 inhibitor. In morning, we heard Dr. Panikar about sulfonylurea, GLP-1RA. But what I'm going to talk about is a drug which is already old, almost 25 years old, but not used as it should be in the Indian context. So a molecule which is a real good molecule and probably very much underused, because in Indian context, according to the START study, whether you go to east, west, south, north, everywhere carbohydrate proportion of eating is high. That is almost 60 to 65% carbohydrate is there in our diet. And that is why our postprandial, the Indian postprandial sugars are higher compared to the fasting sugar. So this is one START AM real world evidence which I am going to present. So we know that there is a need of combination. Why there is a need of combination in immunodiagnostics? Because most of them come with a A1C which is higher than 7.5. Lesser known fact is what we know and don't know about A-carbose metformin FDC data. We don't have the data. We use A-carbose, but the exact data are not available. Most of the physicians, till probably in the audience might be less, but we are using glimepiride metformin or gliclazide metformin as the first drug. So I would not say that everyone, but when there are no other comorbidities like CKD, CVD, and we are not using DPP4 or SGLT2 inhibitor, probably we start with glimepiride or sulfonylurea. So whether this is a drug which can be used here, so that is what introducing START AM was a trial. And newly diagnosed patient, type 2 diabetes, having high glycemic burden, majority of them are having A1C. The patient comes with 8.5 or greater than 7.5. So here PPG is a major contributor, as said according to the START study. And early initiation, we want to hit the patient hard. We want to hit the patient early, rather than starting only on metformin, on a drug which will not then act, which will fail, and then we add another drug. Now the ACE guidelines, which since many years they clearly say that when a patient presents with A1C of greater than 7.5, it is better to start with 2 drugs. Less than 7.5, 1 drug. 7.5 to 9, start with 2 drugs. Greater than 9, they are further going and saying that start with 3 drugs, or you can start insulin also if the patient is catabolic or the A1C is greater than 10. This is what the AAC guidelines, and if you follow that very strictly, we should probably in every patient who is having greater than 7.5, a dual drug therapy should be there. So this is again targeting both. Finally, glucose control is important. Whatever you say, cardiac renal glucose control has its own benefits. So we want both FPG and PPG to be controlled, and a baseline A1C threshold to start with initial combination, as I said, according to the AAC guideline is 7.5, and now all the guidelines are also telling the same thing. And we need a second drug to metformin. Metformin still remains the first drug, all said and done with whatever, but still it remains the first drug, and we want a drug to combine which can cover both the FPG and the PPG. So FPG plus PPG, PPG covered by AGI, FPG covered by metformin. It's very simple. A comprehensive control is done. So consideration for choosing a combination therapy, one is address high carbohydrate intake. We already meant it. Minimizing the cardiovascular risk. Enhanced insulin sparing and beta cells. So metformin again doesn't have any action on it. It is an insulin sensitizer, or it increases the uptake of glucose by the cells. And similarly, the AGI is also not acting on any insulin component. The mechanism of action is as simple. It reduces or delays the absorption of the carbohydrates. So it spares the insulin. So these are the both drugs which spares the insulin. Peak reduces. There is low risk of hypoglycemia, low body weight, better tolerability and safety profile. So we want drugs compared to the sulfonylureas which we are using, the age-old sulfonylureas we are using, and almost in 50% of the patient. So this is what we are getting. Good glycemic control. PPG is controlled by the A-carbose, FPG is controlled by the metformin. Insulin sparing effect, that is very important. So it spares the insulin, no load on the beta cells, automatically the insulin sensitivity improves. Incretin effect, this is one. We are talking about GLP-1 since yesterday, and today also we had a lot of lectures. But A-carbose naturally, what does A-carbose do? The mechanism of action is it delays the carbohydrate absorption. So the carbohydrate goes down into the small intestine, and when it touches the small intestine, it causes release of natural GLP-1. So if you give in high doses, it causes GLP-1, natural GLP-1 release, which is not known to many. So this is very important effect which it causes. Risk of body weight again, because insulin is spared, there is no risk. Risk of hypoglycemia very minimal. Cardiovascular benefit, there are a lot of studies which I am not going to address here, but there are from STOP NIDDM to the Beijing diabetes community, all showed that the risk of MI, risk of MACE reduced. In fact, the ACE trial, which was a neutral trial, so there is no negative trial, there is one neutral trial, almost 2 to 3 trials in one in pre-diabetic, another in diabetes, which showed that it has definitely a good. So we are probably living in an era where cardiovascular, we are, SGLT2 inhibitor almost everywhere it is right, left or center we talk about, but this is a drug which also gives this benefit, and of course a beneficial effect on the lipid profile. So this is how both drugs are complementing each other. What we already know, so there was a typical GLOBE study, observational study with acarbose metformin and uncontrolled DM on other. So acarbose metformin versus metformin therapy, almost 229 patients. This was done by Bansi Sabo et al. And what we don't know, effectiveness and tolerability of acarbose metformin, FDC in a newly diagnosed, remember it's a newly diagnosed patient, as a first line, drug naive. અત્યાર સુધી કોઈ પણ દવા નથી, just we start directly on a fixed dose combination. And of course, we wanted to study the drug utilization pattern of acarbose metformin in routine clinical practice in different patient care. So how is 1 OD, 2 OD, thrice OD, how can it be given and how is it given by the practitioners? So this is what we wanted to do in a drug naive patient. Remember, the patient has come to you for the first time, and this is what the study was. It's a prospective, non-interventional, single-arm, open-label, multi-center, almost 55 centers over there, and 1,728 patients were screened. After that, 1,714 were enrolled at the baseline visit 1, and then visit 2, that is week 6, they were started on metformin with acarbose, and then there were a follow-up visit at 1.5, that is 6 weeks, again 3 months, that is 24 weeks, and 6 months, that is 6 weeks, then 12 weeks, and 24 weeks, and then finally there was one another post-treatment follow-up for 1 month. So they were all newly diagnosed, and of course they were eligible for a DL drug. So they were not having 7 events, they were all were having greater than 7.5 A1C, and with a high FPG and PPG. So this was the primary endpoint which was seen, mean change in the A1C from the baseline at 24 weeks, that is 6 months, and secondary endpoints were change from baseline at 12 weeks, fasting sugar at 6, 12 and 24 weeks, postprandial at 6, 12 and 24 weeks, and then adverse events were also seen, hypoglycemic events, the lipid profile changes, and of course the body weight, which we are again worried about. Body weight was also measured. And treatment patterns, that starting and final dose at 24 weeks, and average daily dose, what was it given. So requirement of any other additional drug was there. So this was all secondary endpoints. So this was a visit-wise data collection. If you see the first baseline, everything was done, starting from demography to prior medication and everything. And laboratory parameters A, B, C, D was done. That is A1C, fasting sugar, PP, and lipid profile. At 6 weeks, again the same. ABC was done, the lipid profile was not done. Third, again ABC was done. I don't understand this 6-week A1C, but still it was done there at 6 weeks. And then at 12 weeks, and then again at the end of the trial, everything was done with, again, including the lipid profile was done. So study setting, outpatient clinic or private clinic, or it was just outpatient clinic, and prescribing, patients were enrolled in the study only when the decision to prescribe this drug was made by the treating physician. The dosage was simple. Prescribed tablet was 1 tablet, 25 to 50 milligram, 25 or 50 milligram of acarbose with 500 milligram of metformin, and patients can be started at a low dose. It's not to start with TDS, but can be started if the patient doesn't tolerate 1 OD. It can be increased to 2, and then you can go to TDS, and probably there was some patient who were on 5 tablets. So just to emphasize that even 5 tablets could be tolerable. So 250 milligram of acarbose and almost 2.5 gram of metformin. So it was all individualized for each patient based on effectiveness and the tolerance of the patient. This was the inclusion criteria. All patients were male and female adult, aged greater than 18 years, newly diagnosed, diagnosis occurred within 6 months. They are eligible, so the A1C is greater than 7.5, in between 7.5 to 9, and no contraindication to acarbose metformin was there, and there was some exclusion criteria. Patient not receiving any of the anti-diabetic. Type 1, no. Of course, acarbose has been now recommended or officially recommended in type 1 diabetes also, and we use it in the dose of 25, or even if the patient is higher weight, we can use it in 50 milligram TDS in type 1 diabetes also. It is the only alpha glucosidase inhibitor which can be used in type 1. Patients with A1C greater than 9, because the patient is catabolic, probably at that time you have to use multiple drugs. Patients with serious infection, pregnant or breastfeeding were not used, females were not used. Of course, women of childbearing age not willing to use contraception were excluded from the study. So this is how the patient was disposed. 1,700 patients, patient screen 1,728, total 1,714 were enrolled, and finally 1,589 completed the study, and out of that adverse event, 12 patients discontinued due to the adverse event, and many other reasons were there. Majority of the patients were around 49 was the mean age. All Asians, Indian, because as I said, the Indians are carbohydrate eaters, whether you go anywhere, and the weight. So we have almost obese patient. By Indian standard, they are all obese patients. 62% were male and 38% were female. 20% of those were 40 years age or less. We see this now. Young patients coming with us, Diabetes2025 also. At baseline, the patient had high glycemic level. The A1C average was 8.06. The FPG 145, PPG was 219, LDL 106. And total cholesterol triglycerides were high, and common associated comorbidities were hypertension. This is commonly seen in all our patients. We see in routine practice hypertension and dyslipidemia being common, and rest of the things are also there in some of the patients because this is a newly diagnosed patient. Commonly observed medication, PPI, vitamin D, statins were there in 124 already. They were receiving statins, ARB, and these were the drugs which were there already on the patients. What was the primary outcome? So analysis of just simple change in A1C from baseline to week 24, a reduction of A1C by 1%. 56 centers, this was with started with 8.06, 7.06 at the end of 24 weeks. This was the primary outcome. So 1% reduction, which is we want. We want it to come below 7. So it's a significant reduction, highlighting the effectiveness of the combination. And if you see the PPG, the same, the PPG control also starts early, and sorry, this is the A1C chart again. It starts early. It starts at 6 weeks and then it goes down at the 24 weeks. So, and no requirement of additional OH in 89% of the patient at the end of the study, and 56% achieved A1C less than 7. So, consistent, effective, starts early. And in 685 patients, in fact, the A1C went down to 6.63 from a baseline of 7.95 at the end of 24 weeks, which was statistically significant, almost reduction by 1.3%. Similarly, the secondary outcomes were postprandial change from baseline, and it started at 6 weeks by minus 37 and went on to reduce the PPG by 56 milligram. So there was a progressive reduction in PPG starting as early as 6 weeks. So finally, we are worried about PPG because, as we said, PPG causes the large studies have been shown that PPG is the main culprit in causing pro-oxidation, pro-coagulant, pro-inflammatory, and CVD risk. So PPG, if the PPG is high, it is worse than FPG for causing more CVD. So that is where this drug is very good in tackling the PPG. Of course, the FPG was also reduced up to 32 milligram and it started at almost 6 weeks. But PPG was significantly reduced, and that is what we wanted, and progressive and sustained impact on the glycemic control because FPS as well as PPG were reduced. Body weight, yes, it seems to be a neutral drug, but at the end of the study, at the end of 24 weeks, it was 2.2 kg reduction. Even 1 kg reduction is good for the patient, for a metabolic health of the patient. So it is good and reduce the risk of complication associated with higher body weight and improve metabolic complication. Significant reduction in LDL, VLDL, total cholesterol, triglyceride from the baseline to 20. So around 21.7% of the total study population were on statin. So that is beyond this patient also, it caused per se reduction in the cholesterol levels. So we know this, how it improves potentially the CV risk reduction. So by PPG reduction, by LDL cholesterol lowering, by body weight reduction, it has multiple benefits. What was the prescribed dose? So it was 50 to 500 milligram once daily for a common prescribed dose, followed by 50 twice daily at the end of. So this was the commonest dose used. Now started with 50 to 500, which is what we also do, or sometimes we start with 25 500 BD and then make it 50 BD. We can go into TDS also, but this was what in this study the mean dose was around 100 milligram of around 72 plus or minus 30, almost 100 milligram of acarbose was used. And this was the side effect again, gastrointestinal side effect. We all know the side effect because it has mainly a GI effect. So it reduces or delays the absorption of the carbohydrate. The polysaccharides which are not absorbed will go into the small, later distal small intestine and the large intestine. The bacteria will act on it and it will cause side effects which are purely gastrointestinal, flatulence, abdominal pain, diarrhea. These are the commonest side effects, and the same was observed in the study. Only 0.94 patient had drug-related emergent adverse event and 0.82% discontinued because of this. So almost 92.7%, almost most any drug has side effect and we have to discontinue for the same reason. Say if you use SGLT2 inhibitor, you have GI infection and we have to discontinue, almost at the same pattern we use it. But this side effect in fact is a testament that it is acting. The side effect itself shows that the drug is acting. The polysaccharide has not been digested, they go down and they are fermented by the bacteria and this side effect occurs. So it's a positive feedback that the drug is acting. Only thing is at best you have to start with a low dose and probably it wanes over time. So this side effect is not so serious. It wanes over time, 1, 2 weeks, 3 weeks. Once it passes, the patient will not have slight discomfort the patient will have, which the patient will tolerate later on. So this is a well tolerated drug. And hypoglycemia, that is what we are worried about, and that is what the sulfonylurea which we are using every time in most of the newly diagnosed patient cause. And this is where the risk of severe hypoglycemia is low and almost minimal or no if you're just using this combination in this study, of course, but if you are just using this combination practically metformin with acarbose, hypoglycemia is almost negligible because both are insulin independent action. That is acting by delaying the absorption, and the metformin is also not stimulating the beta cells. So it is sparing the insulin. The peak of insulin which comes after food in a normal person or a diabetic person also, that is avoided. In fact, it's a blunted curve. Normally, this is how the peak occurs of the PPG as well as the insulin, and this is blunted because of the acarbose, because the acarbose delays the absorption. So this is what mild, moderate, severe the adverse events were. There was no fatality and it's a well tolerated drug. So summarizing, this study was conducted to address the gap on effectiveness, safety and treatment patterns of acarbose metformin fixed drug combination in a newly diagnosed naive patient, drug naive patient. The study design was simple, prospective, observational, multicenter, real world. Newly diagnosed patient, naive, eligible for dual therapy, A1C greater than 7.5, in between 7.5 to 9, and a duration of 6 months was seen. Endpoints were change in A1C, change in the PPG, effect on body weight and lipid profile. Of course, the safety profile, the side effects were seen, and utilization pattern, once daily, 2 daily, and 3 daily. And as we saw, acarbose almost 100 milligram was used by most of the practitioners. So these were the baseline characteristics: 1,714 patients from 56 centers. Mean age was 50 years. The weight, they were all overweight to obese, high glycemic level, hypertension and dyslipidemia was in major comorbidities, and 92.7% completed the study. And if you summarize, this is probably the second last slide. The glycemic control significantly reduce A1C by 1%. Early and consistent reduction till 24 weeks. More than the half of the patient achieve A1C less than 7, and majority achieved A1C less than 7.5, almost 89 to 90%. And FDC only was well enough to achieve significant glycemic control in 90% of the patient. So almost this combination. So better to start with the combination. So effective in terms of reduction, significant reduction of PPG, 56, FPG also was there, benefit on the weight, benefit on the lipid profile, and of course only 0.94% experience drug related, leading to discontinuation in only 0.82%. GI side effect, as I said, was the main, minimal risk of hypoglycemia. Concluding, acarbose metformin provides early, consistent, durable. So you want a reduction also, early also, because hit hard, hit early is our now target. You cannot wait for 1 year or 2 years. You have to give a dual drug. You have to see all the other parameters, body weight reduction, improvement in the lipid profile. So it's a well tolerated in newly diagnosed type 2 diabetes, and thus could be a preferred first line combination in these patients. Thank you.